Okay, well, good afternoon, everybody, and thank you very much for the kind invitation and greetings from a very rainy Dublin. So my task today is to talk to you about the prediction and prevention of cancer-associated thrombosis, which is a significant clinical problem. And I'm going to talk to you a bit about some of our own work, but also give an overview of the field in general. So these are my disclosures, mostly just some funding from Neo Pharma. So just a bit of epidemiology. Of all the VT that occurs, about 20% of it is associated with cancer. So it's a big proportion of venous thromboembolism. And of all cancer patients, up to 20% of them at some point in their cancer journey will have a symptomatic VT, which is a huge number. And if we were to perform an autopsy on all cancer patients, 50% of them would probably have a VTE. So it's a very common occurrence. When comparing patients without cancer, patients with cancer have a much higher risk of first VTE, as I've just said, and also of recurrent VTE. And they also have a higher risk of bleeding, which makes them much more difficult to treat. And Maeve will talk more about that. Something that people don't realize is that VTE is actually the second leading cause of death in cancer after the cancer itself. And more worryingly, the incidence of cancer-associated thrombosis is increasing, despite the fact that the incidence of VT is not increasing. So clearly something is going on. So this is a study that was done by a group in Holland, just talking about the incidence. And just, I suppose, the main thing that they point out is really that there are parallel increases in the uses of chemotherapy and target therapies, in the use of CT scanning, and in the survival of cancer patients in general. And this probably is contributing to the increased incidence of venous thromboembolism. So when we think about the pathogenesis of VT, for those of you who aren't familiar with it, we think about it as having three main contributing factors: vascular endothelial damage, which disturbs the anticoagulant surface; stasis or slowing of blood flow, which can be as a result of vasoconstriction or pressure; hypercoagulability, in other words, an activation of some of the coagulation pathways. And when we think about cancer, we can think that actually all of these three factors are affected by cancer. So it's not really surprising that patients with cancer are at high risk of VTE. So the tumor cell actually does release procoagulant material. It actually even releases some coagulation factors. It also releases inflammatory cytokines. It activates platelets. You also get chemotherapy and anti-angiogenic therapy, which again can cause endothelial damage, affecting the inhibitory pathways of the coagulation system. You also get an inflammatory response. And again, all these things lead to the generation of a thrombus. Then you consider the clinical risk factors. Obesity is a risk factor for cancer. Often our patients are older age, and they've often undergone surgery, and there are periods of immobility as a result of their surgery or other treatments. So all these combine to produce a high risk of VTE. So it's not as simple as one size fits all. The rates of VTE vary according to tumor site. From up at the top here, you've got pancreatic cancer, brain cancer, lung cancer, etc., esophageal, ovarian cancer. And down at the other end, then you've got things like breast and prostate, which have a much lower risk. But the important thing to realize is that breast and prostate cancer are much commoner cancers. So if you think of the number of people affected, there's probably as many people affected in this group as in this group. So the risk of thrombosis is related to many factors. We can sort of divide them into three or possibly four. First one is patient-related, and as I've already said, that older age and obesity are risk factors for thrombosis, and they're common in cancer patients. You also have treatment-related factors. We know that chemotherapy increases the risk of VTE, surgery increases the risk of VTE in both cancer and non-cancer patients. And then you've got the tumor-related factors, like tumor site, which I've just talked about, but also within the tumor site, there are a number of different histological subtypes in most cancers, and different histological subtypes are associated with different VTE risks. For example, clear cell cancer of the ovary is a very procoagulant cancer and is associated with high rates of VTE. Also, stage and grade, advanced stage, high-grade cancers are associated with high rates of VTE. And more recently, it's been appreciated the molecular profile of the tumor also can influence VTE risk. For instance, in colorectal cancer, KRAS mutations are associated with a higher VTE risk. The other thing to consider is that VTE risks persist throughout the cancer journey. Usually patients often present at the start either with a risk with a VTE, which is a cancer subsequently diagnosed, or the other way around. A cancer is diagnosed and then on imaging a VTE is diagnosed. So this often happens. If VTE doesn't occur during that period, patients may develop a VTE following surgery, during hospitalization, during chemotherapy. Hopefully, if they reach remission, their risk will drop back, but it's still not as low as the risk in the general population, which is represented by this dashed line here. Sadly, often the first sign of recurrence is a VTE, and we often see it associated with recurrence, metastasis, and end of life. So it's a constant ongoing process. And when we consider the risk, we need to consider risk assessment as an ongoing process. Unfortunately, VTE is a very treatable disease and it's also preventable. And for those of you who are unfamiliar with it, the two main drugs used for this are low molecular weight heparins, which are given by injection, and direct oral anticoagulants, which have become available more recently. Just to say that low molecular weight heparin tends to potentiate the effect of antithrombin and creating an anti-10A effect. Direct oral anticoagulants tend to act more directly on 10A, and you also get inhibitors of thrombin like dabigatran. The 10A inhibitors are rivaroxaban and apixaban, which many of you may have come across in your practice. So if it's preventable, where are the opportunities where we can intervene and prevent VTE? So the guidelines recommend post-surgery using low molecular weight heparin, and during chemotherapy using direct oral anticoagulants. And there's also recommendations during hospitalization, but I'm not going to talk about that today. But it's not quite that simple because when you're giving an anticoagulant, there's always a bleeding risk. And you're giving it for prophylaxis, this is a serious consideration. Also, with increasingly complex cancer drugs, you have to consider drug-drug interactions. There's good evidence that there's very poor adherence of the guidelines, both surgery and chemotherapy. It's very poor adherence by physicians, and also there can be very poor compliance by the patients. So what are the guidelines for surgery? Well, guidelines recommend extended prophylaxis for 4 weeks with low molecular weight heparin to prevent post-operative VT after major laparotomy in cancer for patients at high risk. These are patients with pelvic abdominal surgery for cancer. What about laparoscopy? Well, it's also recommended for laparoscopy in the same way as laparotomy. But again, this is not straightforward. Minimally invasive surgery has been increasingly used, and rates of VTE are actually very low, much lower than the rates of VTE on which the guidelines were based. I should say I didn't have time to go into the actual trials that backed up the guidelines, but most of them are based on clinical trials where patients are screened for VTE. And that's very different from the real world type situation. Many real world studies have shown that actually the rates of VTE are lower in those studies than in the clinical trials. The other issue is that VTE occurs in approximately 5 to 6% of patients despite low molecular weight heparin prophylaxis. And that's a major problem. And as I've said, epidemiological studies or real world studies actually don't show that extended prophylaxis in the majority of cases reduces VTE. That is part of the reason why the guidelines haven't really gained a huge amount of acceptance. So this is a recent study. There are many studies looking at extended prophylaxis, but this is just an example of a recent one on pancreatic cancer. And pancreatic cancer is actually the cancer with the highest risk of VTE. And as you can see here, this is the VTE occurrence rate at 90 days in a year. And in the blue, you've got no extended prophylaxis. In the orange, extended prophylaxis. And there's actually very little difference between them. It's not significant. You see a slight reduction at 1 year, but again, that's a long time since their cancer surgery. In endometrial cancer and gynec cancers, which is what I'm interested in, there are a number of studies which actually show that there's no difference, no benefit from extended prophylaxis. And several authors have suggested that possibly we should be stratifying patients and risk assessing them to see whether they actually need extended prophylaxis. So how do we do that? Well, the guidelines recommend we use the Caprini risk score. Okay, and this is the Caprini risk score, if any of you have ever used it. It's incredibly complex. Malignancy automatically gives you a score of 2. It's not very user-friendly, and it's definitely not been used commonly. The other issue with it is it's not particularly sensitive. this is a study which was done on gynecological cancer patients, and when they used the Caprini risk score, 92% of them were in the highest risk category. However, of those high-risk patients, only 3.5% got VTE. So it wasn't terribly good for picking out high-risk and low-risk patients. However, the VTE patients who did score higher, they did score higher than the non-VTE patients, but that's not hugely useful when you're trying to decide on prophylaxis. This is our own score, which we call the thrombogyne score, which we developed in 2020 in James's using multivariate analysis. And I won't go into the details in the interest of time, but it's basically a 3-point score. We produced the score as a result of putting in a whole series of risk factors and picking out the ones that were independent. And these were the 3 that were independent. Hemoglobin pre-op less than 11.5, BMI greater than 30, and chemotherapy either before surgery or in the follow-up period afterwards. And as you can see in the derivation and validation cohort, you get a nice distinction between the 3 groups, from a very low risk at maybe 1.5% up to a risk of about 20% in the high risk group. So this group might be the group that you might consider maybe don't need extended prophylaxis, and perhaps this group and this group maybe do. So this was a retrospective study which we did here, looking at patients before the introduction of extended prophylaxis and after the introduction of extended prophylaxis. And this was done by Faraz Abusada. So what we did is we classified them according to the thrombogyne score and looked at the intermediate to high risk group and compared those who got extended prophylaxis from those who don't. And what we found actually was that in the intermediate to high risk group, they did actually benefit from the extended prophylaxis, and it reduced the rate of VTE by approximately a hazard ratio of 0.5. So, and if you look at the low risk group, then there was actually only 6 events, and extended prophylaxis, if you did the same exercise, had actually no effect on that low risk group. This is just an indication of how you can use a simple score to help guide prophylaxis. Another approach which has been recently suggested is that we could use direct oral anticoagulants after discharge from hospital as extended prophylaxis. And this is a study of colorectal cancer patients where they used rivaroxaban or placebo following discharge, following laparoscopic surgery for colorectal cancer. And as you can see here, they saw a significant difference between patients on placebo, who had a rate of 3.9%, compared with 1% in patients who had rivaroxaban. So this was significant, albeit the actual rates are quite low. Now, this has been attempted also in gynecological cancers, and the Valeria trial was a trial that was set up to look at this, looking at rivaroxaban versus enoxaparin. However, the rates of VTE were so low that the study had to be discontinued. So this is an increasing problem in that as care improves, some of the VTE post-surgery is reduced in real-world studies. What about breakthrough VTE, which is a problem? So I've mentioned already that a high number of patients get VTE despite appropriate prophylaxis. This often occurs in hospital. So what really is the issue here? Is it that possibly they need a higher dose of low-molecular weight heparin or a different approach? It's unlikely to be an issue of compliance if it's happening in hospital, but perhaps it is an extended prophylaxis. This is a study we did to look at this. In James's, patients get a fixed dose of tinzaparin, 4,500 units, if their BMI is less than 40. They get a weight-adjusted dose if their BMI is greater than 40. These are gynecological cancer patients undergoing surgery. So we looked at these patients as part of our biobank, and we took a sample 4 hours following injection of their tinzaparin, between day 2 and day 5 after their surgery, and we looked at their anti-10A levels. Now, their anti-10A levels aren't normally recommended for prophylaxis, but we wanted to see what kind of effective levels we were seeing. And this is what we found. So on the left here in the blue bars, you can see the anti-10A levels. The recommended level is between 0.2 and 0.4. Now remember, these are peak. Normally you get a dome-shaped curve. So you can see that more than half of them actually have levels below the lower limit. These are the patients who developed VT post-surgery. And you can see that their levels are actually lower than the lower limit, apart from this one. and that overall their end-to-end levels are significantly lower than these patients. All of the VTE patients got a fixed dose. And this is a very small weight adjusted group, and you can see that their levels are much better, and they're significantly greater than both the VT group and also the fixed dose group. That's suggesting that possibly weight adjusted dosing might be more effective. However, we would need to test this in a randomized trial. And in tandem with this, we looked at thrombin generation, which is a measure of the ability of the system to produce thrombin in a group of patients pre-op and then day 5 at their peak anti-10A levels and post-op. So you can see here that these are 5 patients who've developed VTE, and you can see that they have a higher thrombin activity even at peak post-low molecular weight heparin. So clearly these patients are different in some way. Okay, so what about the guidelines for chemotherapy? Well, the ASH guidelines were changed in 2021, and subsequent guidelines have also been changed as a result of 2 clinical trials, which showed that DOACs given to patients at an intermediate and high risk of thrombosis reduce VTE in patients undergoing chemotherapy. So it's now recommended that ambulatory patients with cancer at intermediate and high risk of thrombosis should receive DOACs, or should be considered for DOAC prophylaxis. And that the risk assessment tool that was initially recommended was the Coranis score. And for those of you who aren't familiar with it, this is the Coranis score. It's a very simple score. All of the parameters are easily available. It's not a research tool, but it is very dependent on the site of cancer, and this is a criticism of it. And Coranis score of greater than 2 is considered to be an intermediate or high risk. So this is from the original paper by Corana. You can see there's 3 nice groups, and the top group here with the Coranis score of greater than 3. This is a mixed population of cancer patients. Have a level of 7% of VTE during chemotherapy compared to less than 1% in those at low risk. However, it is very dependent on tumour site. And as you saw, part of the score is tumour site. It's got very poor sensitivity, and it certainly doesn't perform well in cancers of a single type. This is illustrated by this study here, which was actually published by a related group to Corana. And these are the different scores here, the different coloured lines in lung cancer patients. And as you can see, there's absolutely no difference between them. So it's completely ineffective in this group of patients. So then people moved on and thought, well, perhaps if we added some biomarkers to the Coranis score or to other scores, or used them independently, maybe this would help to predict VTE. So I don't have time to go into the merits of each one, but these are sort of the commonly used ones. D-dimer you're all familiar with, very low sensitivity for VTE, but certainly used a lot as a diagnostic tool. P-selectin is a research tool, really, as is thrombin generation, although it's becoming more commonly available. Factor VIII activity is clinically available and has been shown consistently to predict VTE. And the thrombin fragment 1.2 is a fragment produced when thrombin is activated. And again, it's a research tool. So a group in Vienna who've done a lot of work in this area combined D-dimer and P-selectin over at the 75th centile, scored their patients with the Coranis score with these 2, and then produced different risk groups. And as you can see, it's really effective. You get in the high risk group, 30% of patients actually get a VTE. This was very encouraging. However, people were slow to adopt it because P-selectin is very expensive and it's not clinically available. And then in 2017, a group in Holland, and there's been other groups similarly who've done this, looked at all the different risk scores. There are a couple of other risk scores which I haven't time to go into, called the PROTECT score, which includes the type of chemotherapy, the CONCO score, which includes performance status. And they looked at all of these scores, including the Vienna score, which I've just showed you, and Coranis score, in a large cohort of patients. And they actually showed that none of them were effective in predicting VTE. So clearly, it's not as simple as using the Coranis score, and we have more work to do in predicting VTE. So we did something similar with our thrombin score. We added ETP and D-dimer. In our population, ETP and D-dimer, although D-dimer is very variable, as you can see, we do see an increase in patients who develop VTE compared with those who don't. And we added that to our thrombin score. and used at 25th, 75th percentile. And as you can see, the black bars represent the extended score. The extended score does predict, particularly in the high risk group, does predict a high number of VTEs. However, doesn't really improve things in the low risk group. So we think that actually this type of score is useful for identifying those high risk patients who might require a different type of intervention, for instance, maybe a weight adjusted prophylaxis or a higher dose. But again, this needs to be tested in a clinical trial. We then looked at another marker, factor 8C, because as you know, thrombin generation is not really available in many labs, but factor 8 is. And this is a study which we're going to present next week in ICTIC, which is a cancer and thrombosis meeting. And we looked at factor 8C combined with the Khorana score and combined with our score, the thrombogine score. And as you can see, it doesn't really have any effect on the Khorana score, but it does nicely delineate the three groups with the thrombogine score. And when you look at them then over time, this is over 6 weeks, 6 months, you can see this high risk group scoring 3 to 4, you can predict VT up to 20%. And again, in this low risk group, who again may be able to avoid prophylaxis, they have very little rate of VTE. So again, just another way to try and stratify them. There are other cancer-specific risk scores as well. This is the IMPEDE score for multiple myeloma, which is actually now in the guidelines. Again, a score which includes many of the many clinical parameters that are clearly available. And again, you can predict VT very effectively with this. You can also use biomarkers to guide prophylaxis. This is a study by an Australian group, which has just been published, which used fibrinogen and D-dimer combined to guide prophylaxis with enoxaparin in patients undergoing chemotherapy. And as you can see, there's a significant reduction in VTE in the patients who had enoxaparin. In fact, they're reduced down to the low risk group. So what about the patient? The guidelines say that we should consider we should consider the views of the patient and the relative benefits and harms, costs, etc. However, as many of you know, awareness of cancer-associated thrombosis is really low. Well, this is a study from the World Thrombosis Stake Group, and for instance, for chemotherapy, only 20% of patients knew that it was associated with thrombosis, and 70% of patients don't get an education on VTE and how it's manifested. This is a recently published study showing a risk stratified decision aid, which facilitates shared decision making, because we don't really know what's important to patients. Is bleeding a major fear? Are they more afraid of bleeding than they are of the thrombosis? How important is it to them that there is no interference with their cancer treatment, etc. So this tool developed by this group is actually for use in shared decision making in extended prophylaxis. But there's also a need for this in cancers, in chemotherapy associated prophylaxis. So future directions. We know that new targeted therapies do increase VTE, but we don't know how. So some of the work that's ongoing at the moment is actually to look at this and try and understand it. I think it's important that there's an increased role of patients in decision-making regarding prophylaxis. I think personalized prophylaxis, like everything in cancer treatment, is the way to go rather than a blanket risk assessment tool. And we also need to dynamically risk assess patients throughout their cancer journey, not just one-off at the start. We need biomarkers that are robust enough to use at different stages of treatment and which are accessible. Proteomics are likely to generate new biomarkers, and there's several studies underway to do this. And definitely artificial intelligence has a role in generating risk assessment models and also in the use of risk assessment models. With that, I'd just like to thank the members of our group, particularly Mark Ward, as beside most of his work I showed today, Sharon Toole, who manages our biobank, which actually facilitates all of the work we do, and Zimi Marchaki, who's recently moved to Cork, who did some of the work that I showed today. Finally, I'd like to thank our patients and their families. Thank you very much.
Thank you very much. I don't see that any questions have come in as yet through the chat group message. So what I might do is I'll introduce Dr Maeve Crowley, and we can do all the questions at the end if people have thought of them. We'll do all the questions at the end. So Dr Maeve Crowley is a consultant hematologist here at CUH. She studied medicine in UCC. She completed her higher specialist training in haematology in Ireland, during which time she completed an MD. Oh, apologies, my camera's not on. Sorry. During which time she completed an MD on the subject of evolving hypercoagulability in patients with plasma cell disorders. She then went on to work as a clinical fellow and a consultant hematologist in Hemostasis and Thrombosis Centre in Guy's and St Thomas's Hospital in London, the UK, before returning to Ireland to take up a post in the Comprehensive Coagulation Centre here in CUH Ireland. She is a fellow of the Royal College of Physicians in Ireland and the Royal College of Pathologists in the UK. And her presentation is the management of cancer-associated thrombosis. And again, I'd just like to remind you that you're being recorded and to put questions into the chat box. Thanks.
So thanks very much for that kind introduction. So I'm going to jump straight into management here because Dr. Norris has so elegantly given all the background. Sorry, now I'm having problems advance. Oh, there we go. So my main disclosures are honorary from Leo Pharmaceuticals and Takeda, and then I'm the National Clinical Investigator for Aster and Magnolia, which I'll refer to a little bit later, just to lay my cards on the table. So this is what I'm hoping to cover today. So looking at our different treatment options with low molecular weight heparin, direct oral anticoagulants, and then what happens in most of our clinical practice, which is outside of the clinical trials, looking at the availability of guidelines, very briefly on prevention, and then looking at agents in the future. So as most people will know, low molecular weight heparin is the gold standard, and this is based on Agnes Lee's study from 2003 called the CLOT study. So you can see, depending on what country the study comes from, it depends on how they call it. So Agnes has been very practical. So just the CLOT study, and very clear warfarin versus dalteparin. And there was a big advantage in preventing thrombosis in the dalteparin group, as you can see here. And this has been replicated in other low molecular weight heparins. So this is the CATCH study that again, Agnes Lee published in 2015. The big thing to think about here when I'm talking about the other studies is, number one, because CLOT is the first study, it's considered the gold standard and is the comparator to all the other studies, other than the other low molecular weight heparin studies. And we don't use dalteparin here, but what's interesting about dalteparin dosing in CLOT is that they give 100% of the dose for the first month and then 75% of the dose for the next 5 months, which is not something we do with any other anticoagulant. So this was kind of the gold standard for many years, and then there was the onset of the DOACs. Oh, sorry, I skipped too far. Now, there's a lot of kind of feelings about whether you should give once a day or twice a day low molecular weight heparin in patients with cancer, and then what agent should be used. Certainly, dalteparin and tinzaparin are the traditional ones, but a lot of people would favor kind of a BD enoxaparin. So this is looking at some data from the right registry, and so people who aren't familiar with this, it's more of a European registry, and it just looks at real world data. So these are people who were put on any of the low molecular weight heparins and kind of a once a day or twice a day enoxaparin dose, just to see kind of what happened in terms of bleeding, recurrent thrombosis, and this is in the first 6 months of treatment. And as you can see here, there's actually very little difference in whether you were on enoxaparin or dalteparin or tinzaparin, and then whether you were on BD enoxaparin or once a day. So I think we can be confident that starting someone on a treatment is the most important thing, and we don't have much evidence to guide us on which treatment other than individual patient factors. So then moving on to the direct oral anticoagulants, edoxaban was the fourth licensed DOAC, third 10A inhibitor, and so they went out hard and early for cancer data. It's very elegantly named the Hokusai Cancer Study from Japan. And so they looked at just over 1,000 patients with active cancer and symptomatic DVT or PE with an ECOG of less than or equal to 2. So as I said, this CLOT regimen of 100% of dalteparin for the first month and then 75% for subsequent months is compared against edoxaban. And what we're looking for here is non-inferiority, and this was achieved. So they had a composite endpoint looking at bleeding and thrombosis. So there was less recurrent thrombosis in the edoxaban arm, but more bleeding, especially in the GI and GU cancers. So this is kind of a warning, and it's been taken up in subsequent studies and in guidelines. At about the same time, rivaroxaban was also available, and the British, who I had the SELECT-D group or study. So this looked at a much smaller number, 406, but kind of a similar patient population, active cancer with symptomatic VTE and an ECOG of less than or equal to 2. Again, the comparator was dalteparin. They looked at rivaroxaban, and again, they achieved non-inferiority, but they did have a little bit more bleeding in the rivaroxaban group. The Italian Caravaggio study then was able to learn from this. So they were a little bit more selective in who they looked at, who they recruited, but they still looked at more than 1,000 patients. So again, active cancer, symptomatic VTE, but they excluded the brain tumors because they were anecdotally considered to be high risk. Same comparator, and again, they achieved non-inferiority, but they were the first study not to have this kind of bleeding signal. So like less recurrent thrombosis, but not enough to show superiority. But they had no increased bleeding. So when we look at a meta-analysis of patients on kind of in terms of bleeding and thrombosis in the cancer-associated thrombosis cohort, we know that they're both at high risk of thrombosis and at high risk of bleeding. And sometimes we're weighing these up when we're starting someone on a treatment. So this is a meta-analysis published in 2020 in thrombosis hemostasis. And so it showed that if you take all comers, so all agents and cohort and randomized controlled trials, then thrombosis, this seems to be a much bigger cause of death than bleeding. If you break it down a little bit, this holds for the randomized controlled trials where recurrent thrombosis seems to be double the risk of death than the bleeding issue. It's a little bit not as convincing for the cohort study. And then low-molecular weight heparin, again, similar risks. Vitamin K antagonists, which you don't really use much in this cohort, so there will be older studies. It's reversed, and the bleeding is more of an issue than thrombosis, and that kind of makes sense because we know that it's harder to stay in range when we're on multiple medications and when we're on changing regimens, using pulses of therapies. It's much harder to keep a therapeutic INR. And then going back to the DOACs, recurrent thrombosis is a much more common cause of death than bleeding. But I just like to bring the fact that the confidence intervals are very wide here. So these are more suggestions than kind of anything that we really need to act on. But the main thing to take home is that your patients are at risk of both bleeding and thrombosis, and we just need to treat them in as safe a manner as possible. The British Society of Haematology have just brought out a new guideline on the management of cancer-associated thrombosis. So like what Lucy was talking about, site of cancer is really important. And from the DOAC trials, we really pull out the gastrointestinal and urothelial intracranial component and kind of consider those the high-risk people. And that will kind of impact on what we give. Renal impairment will also be important, as well as drug-drug interactions. But patient choice is a really significant issue. And I suppose when we only had low molecular weight heparin to use, everyone talked about how wonderful it would be to have an oral agent, and we were putting people through so much treatment burden. However, if you're very nauseated, if you're on multiple medications, sometimes it is easier to have a parenteral anticoagulant. So I think people have different opinions about this and different values, and it is important to talk to people about it. Here's the first time I'm going to mention that nearly all the data is for the first 6 months. And then after that, it's kind of the Wild West. Most people will elect to continue if the bleeding risk is low and the cancer is still there, but there isn't really any good data beyond that initial 6 months. So all those studies I've referred to previously are the first 6 months of treatment. So then we go to the real world and what we do if these beautiful studies that we've looked at don't work. So the most common issue is that there's a recurrence and we need to consider intensification of treatment. So if you're on a low molecular weight heparin, it will be standard to increase your dose by 20 to 25%. If you're on a DOAC, most people would switch to low molecular weight heparin. There's no kind of evidence to guide that. It's very much a practice-based thing. But the advantage is that you've got a lot more flexibility in dosing with low molecular weight heparin. So when you're on a DOAC, there's really no evidence about going on a higher dose. Whereas with low molecular weight heparin, it's very standard to increase your dose. The main thing to think about if you've had a recurrence and you've changed the treatment is to see how the patient responds. Is their leg getting smaller? Is the pain reducing? Is their breathing getting easier? Because quite often it can be quite hard on imaging to see kind of definite improvements. But if they're getting better, that's probably the most important thing initially. As I mentioned, randomized data for the initial 6 months, but after that, it's kind of physician's choice. With regards to central venous access devices, this depends on whether you still need the CVC or not. So if not, generally you would take it out. If you do still need it though, and it's working, even if you've had a catheter-related thrombosis, it would be very acceptable to leave it in and anticoagulate with it. And kind of as long as it's in, it's kind of considered a risk. So, and that sounds very straightforward. And if it was only the CVC related clot, it would be. Generally, thrombocytopenia sticks its hand up and gets involved, and that complicates things. But generally with cancer-associated thrombosis, the key is in the acute phase to get as much anticoagulation in while you can in the safe possible way. So anticoagulation and thrombocytopenia are really common. The important things I always think about are how severe is the thrombocytopenia and how long is the thrombocytopenia going to go on for. If we think about the randomized control trials, especially the DOAC ones, they excluded all the grade 3 and grade 4 thrombocytopenic patients. So they had the idealized patients in these trials, but not the ones that we see commonly in the clinical practice. So if your platelet count is 50 or above, most people are happy to continue on anticoagulation at a full dose. If it's dropping, then you need to make a decision about kind of what's your clot burden like. How long do you think you're going to be? So are you at the nadir of your thrombocytopenia, or are you on the way down? How long would we kind of anticipate this to be going on? And then when you can make a decision between kind of reducing down your dose of low molecular weight heparin, so thinking about a prophylactic or a 50% dose reduced dose, or giving some platelet transfusion. But most of the guidelines would say that platelet transfusion is kind of a maximum of 2 weeks. So sometimes with a lot of clot burden and a high risk period, you may try and get the platelet count above 40 or 50. But with the grade 4s, then we know that this is not achievable with transfusion in general. So we need to kind of think about other things. Obviously, filters are mentioned here, but very rarely used, because obviously if we're inserting them, we're going to cause more tissue damage, there'll be more tissue factor release, we'll have more clotting at that site, and we're not actually treating the clots, so the other clots will get bigger. And this is kind of what they suggest from the European Society of Hematology. This is the BCSH guideline, so that recently published guideline. And again, they kind of break it up into, is the clot new, is the clot older? So we know that it's very hard to lyse a clot after 2 weeks. So obviously the first 2 weeks are the kind of the hyperacute phase, and then after that, 4 to 6 weeks, you're thinking it's a new clot, but I'm not quite as worried as that first 2 weeks. And then going further on, we're a little bit looser on our treatment if it's considered unsafe. But obviously, if the platelet count is adequate, continuing anticoagulation is the best thing to do. And I'd just like to say that this is mainly kind of expert guidance and kind of accepted practice, rather than having a very robust evidence base below it. A very common question that comes up here, given we're a neurosurgical center, is anticoagulation and brain tumors. So again, a lot of expert guidance regarding this. Initially, there was some thoughts that the DOACs had a greater bleeding risk for low molecular weight heparin in this. And so if we look at the DOAC studies, certainly brain tumor patients were excluded from Caravaggio, so we don't have apixaban data. In Hokusai, it seemed to, if you look in the supplementary data, it seemed to favor low molecular weight heparin over edoxaban, but there wasn't enough numbers, it was underpowered for this. And then this is also an issue in SELECT-D. If you look at how many brain tumors were there was like 3 brain tumors. And if we think SELECT-D has over 400 patients, so it's really not representative and really not good for guiding practice. In this meta-analysis looking at 1,600 patients, this is from retrospective data, so probably more reflective of real-life practice, then actually DOAC seemed to be a little bit safer. But again, there's a lot of heterogeneity in the studies. And if we look at kind of primary brain tumors versus metastatic brain tumors, when it's broken down that way, certainly with the primary brain tumors, seems to favor DOACs, but it's more equivocal for the metastatic brain tumors. But I would put the caveat here that this is all retrospective data. So a lot of times when people are afraid of bleeding, there were people into low molecular weight heparin group, and that's why it looks worse. And the people that we're happier with were treated with DOACs. So there's a kind of, it doesn't look more unsafe from a DOAC point of view, but I would be kind of not jumping straight into it being first line for absolutely everything. There's a guideline available on this topic, and it's basically choose your guideline, but all the big ones, the American Society of Hematology, the American Society of Medical Oncology, clinical oncology, and then European Hematology Society. And there's some kind of subgroup guidelines looking at specific things like neurological and vascular complications. And then obviously this is the most recent cancer-associated venous thrombosis guideline. Patient education is really important. So as part of the new National VTE clinical program, we have a patient information leaflet subgroup, and people felt so strongly about it that the Cancer and Clots guideline, or PIL, was the first one that was worked upon. So hopefully we'll be launching this soon. So it's something that we'll hope to work with medical oncologists and radiation oncologists and malignant hematologists, trying to kind of be able to educate patients that they know about their risk. I'm very briefly going to talk about thromboprophylaxis, because obviously prevention is the best form of management. But Dr. Norris has really covered it very elegantly. So from a medical inpatient point of view, there's very little randomized data for cancer patients specifically, but Metanox and Prevent had a significant proportion of cancer patients. There's no definite benefit to extended thromboprophylaxis in medical oncology patients, but there is reasonable data for extended low molecular weight heparin thromboprophylaxis for surgical oncology patients. And having left Dr. Norris's group and come to Cork, Zibby and I worked on the DOAC thromboprophylaxis guideline for gynecological malignancy patients in COMH that has been rolled out. And then just looking at the big DOAC thromboprophylaxis trials, AVERT and Cassini are the big ones. And again, they use this very blunt tool of the Corona score in AVERT, and excluded all the patients that I have most to do with. Now, what's interesting is that AVERT looks much better than Cassini, but AVERT is also much more real life in that they don't do any screening. They just risk stratify their patients and gave them apixaban or not based on this, and then managed based on symptoms. Whereas Cassini did a huge amount of screening duplex, both legs, and then every 8 weeks, which is not really reflective of clinical practice. And so while they thought they were going to get a benefit, actually their results were less good. Moving on to the future. So agents I've talked about so far really have been the factor Xa inhibitors, roxaban, apixaban, and edoxaban, and then the low molecular weight heparins. There's very little cancer-associated thrombosis data for dabigatran, just not somewhere they've gone. So we don't really use it that much in that area. But now anticoagulation is moving up the intrinsic pathway, and we're looking at the contact pathway a little bit more. So the factor 11 inhibitors are kind of the furthest along study-wise, but there's also some factor 12 work going on. And this is because when we're looking at the kind of ideal anticoagulant, the big thing that we're not sorting out is the bleeding risk, okay? So many things have been dealt with the direct thrombin inhibitors and the 10A inhibitors, but bleeding is still an issue. So we're still not got that sweet spot for anticoagulation. So why factor 11 is very attractive is that patients with inherited factor 11 deficiency have very low rates of thrombosis, but they also have relatively low rates of spontaneous bleeding, which would be very different from people with inherited factor 10 deficiency, factor 2 deficiency. So abelacimab is probably the furthest along, and that's factor 11 and a factor 11A inhibitor, and it's been shown to be efficacious in preventing post-operative VTE and stroke. It's attractive for cancer patients in that while it's parenteral, it's a monthly subcut injection, so it significantly reduces treatment burden. However, just a caveat would be that the Oceanic AF study, which is asundexian, which is kind of the factor 11 DOAC, that was stopped early due to lack of efficacy. So we still need to wait and see what the final results are. In Ireland at the moment, we have the ASTER and the Magnolia trials open. So ASTER ANT007 is for all patients who would be suitable for a DOAC, and the comparator is apixaban. And again, we're looking at 6 months of data. And they are allowing brain tumors in as long as they have been treated, which is good. And then the Magnolia study, or ANT008, is for GI/GU cancers. So basically the people who wouldn't be suitable for a DOAC based on their site of cancer. And they're abelacimab versus dalteparin, and it's that clot regimen for dalteparin again. So worldwide, we're probably at about 30% of recruitment for 007 and 20% for 008. So it's very much a case of watch this space. So just my take-home points is that thrombosis is a common issue in patients with cancer, and they need to be educated about it. And hopefully this will be aided by the National Patient Information Leaflet. There's randomized data for many treatment options, but this doesn't always address the challenging cohorts that we actually see in clinic. The standard of care is evolving, and as we have new agents, we need to put patients at the center of our decision-making. There are many international guidelines there to support our care, and there are new agents emerging. So thank you very much for your attention.
Great, thank you very much, Maeve. Now, do we have any questions? We don't have any questions as yet coming in through the box, but I'll just have, I'll start with one question for Lucy Noris, and I also have one question for Maeve. I just wanted to say very interesting about the thrombogyne score. That's a really interesting development for that group of patients. I mean, do you think that is it a combination of different scores for each different cancer is the way forward, combined with the biomarkers that you mentioned in terms of stratifying these patients and determining which are the ones that would be most benefit from extended prophylaxis? And then the other question I had is for those with high scores, that say extended prophylaxis would be recommended. Do you have risk assessments for bleeding, and which patients would you avoid, despite having a high risk, as the ones that you would pick out and avoid?
Firstly, as to answer the first part of your question, I do think that, we need cancer-specific risk scores. There's a lot of resistance to this, because they think, oh, well, it's thrombosis, just give the one thing. But like every other form of cancer treatment is individualized, personalized, derived from whatever mutation the patient has. So I just think this needs to be incorporated. And I think artificial intelligence is going to be our friend here, because eventually we're going to have a mutation profile for our cancer patients that possibly could be integrated into their VTE risk and their other risk factors. And you come up with something which would give an indication of their risk of thrombosis. I definitely think the sort of a once-off before treat. The other thing is many things happen to a patient during the chemotherapy. So I don't think it's ever going to work that you just screen somebody once and then that's it, that's their prophylaxis or lack of prophylaxis. And I think the patient view is very important because, as you said, bleeding risk is an issue. And it's a balance, and there are tools, but I just think there's a school of thought now that predicting thrombosis on its own is not enough, that you need to predict the balance between thrombosis and bleeding for all of these things. So these things are getting more and more complicated, but I think possibly because of machine learning and artificial intelligence, it will be possible for us to manage all these things rather than people trying to work them out. So it's an increasingly complex, people are very resistant to the idea that it is complex, but it is. And, as well as that, I think the lack of knowledge from the patient about what the patient feels about this, whether they think the risk of a clot is a big issue or not, or whether they're more afraid of bleeding. That's really not something that's known in the cancer setting. So maybe Maeve would like to comment on the bleeding risk assessment in high-risk patients.
Yeah, I think it's very difficult. I would agree fully. I mean, our best prophylaxis data for anything is hip and knee surgery. There's loads of randomized controlled data, and every drug company, bar actually Bayer with their failed Oceanic, have gone with the thromboprophylaxis in hip and knee first, because it's such a homogenous population, and therefore they get lovely models out, and they get their license for their drug. And we're trying to push together a hugely heterogeneous group of conditions with hugely heterogeneous treatments, and say that we can do a very simplistic score in 2 minutes, and that we will kind of sort everyone out, which is very naive of us. And I think cancer treatment is only getting more complicated. We're not losing complexity. So I think, we'll probably need to break it down by disease a little bit more and treatment. We've never been very good at predicting bleeding in any kind of anticoagulated population, and mainly because all your high risk factors for bleeding are high risk factors from thrombosis as well, nearly. So I'm not sure the VTE bleed probably came out the most recently, which is one of the first kind of VTE ones, because we've always been kind of using atrial fibrillation bleed risk things, which are slightly different. But again, it's a very, very kind of broad thing. And obviously, if you pick out a high risk person, that's easy. But saying everybody else is low risk is not always helpful. So I think site of cancer seems to be one of the big things. And then I think they're going to have to start including thrombocytopenic patients into some of these trials, because they're answering questions on this idealized cohort, which is, we know why, because that's why they want their license and they want the trial to work. But when you're trying to apply that trial then onto who you actually see in clinic, I've just had someone in with thrombocytopenia for 6 weeks, which I thought was never going to recover. But things like that happen, and you don't know. And these people are not in any of the trials, so you're just kind of dependent on experts in the area going, "Oh, this is what I would do. This is my approach." But it's a very predictable risk, and we just probably need to include it a little bit in our studies.
Very good. I had one other question, actually. This one was for Maeve. Was just the recurrence or the propagation or new thrombosis for patients that are already on anticoagulation. Just from personal experience, this is kind of been something I've seen in patient cohorts that generally tends to be a very poor prognostic marker. Is there sort of retrospective data or data out there that supports that, and is there anything in terms of counselling patients who have had a further thrombosis while already anticoagulated in terms of their thrombotic risk and also their cancer risk?
So I think it depends on the setting again. So I mean, if you've had a new clot and we've just started you on a platinum agent, then we'll all kind of go, not that it's okay, but we've done something to increase your risk, and that's not okay. But we're happy to kind of deal with it because we know the platinum isn't forever. We can identify the high risk period. However, if you're seeing someone in clinic who's kind of 6 months out and is just about making that criteria for cancer-associated thrombosis, they're just finishing their 6 months treatment and suddenly they've propped up with something else, or early in the treatment where they've had their surgery and you're really happy, especially in like a breast cancer along with especially the breast, they may not be on anything else. That's a very worrying sign for the cancer itself being badly. I mean, like everything else in the body, you lose hemostasis as you get sicker. So you clot more, you bleed more, everything falls apart. And I think unless we have a nice kind of clean reason for it, like starting a very prothrombotic treatment or having put them through cancer surgery or something like that, it is a very worrying sign. Although we know, like in pregnancy, that these are kind of higher risk for recurrences anyway. So sometimes then it's just about looking at, were we able to anticoagulate them? Because we may not have been. Or certainly we had an incident recently where someone had a 12-pound tumor taken out in the mat and no one reweighed them. So obviously that's the opposite problem. But on cancer treatment, things like weight change, oral intake change, things like that. And we just have to be very careful about, are we actually administering the treatment that we think we are? And not just are they taking it, but have we adjusted it? And I suppose what Lucy said is very kind of pertinent about kind of reassessing frequently, which is very common in the obstetric cohort, which is another cohort. Like they have their booking. If they come in, they're risk assessed. They're risk assessed after delivery, because we don't know what happened. You can't predict what's going to happen in delivery. So it's this kind of different time points and different assessments I think are needed. But always push up the heartburn.
Okay, very good. Is there any other questions now from the group? Okay. Okay, we're just coming to 2 o'clock now, so that is our time. So I think with that, so I'll wrap it up. I'd like to thank again our 2 excellent speakers for today. I think it was an absolutely wonderful talk, certainly extremely relevant and topical for the group that we look after. So I'd just like to thank everybody for attending and thank our 2 excellent speakers.